much. Okay, so thank you very much for having me. I'm delighted to be here with you. And I'm actually coming to Manchester next week, so it feels kind of very odd. I'm doing this work as part of a bigger project that is funded by the Wellcome Trust. The project is called, there's no app for this, Managing the Migration of Health Data in Sub-Saharan Africa. And in that project, we ask questions around, one, what health data is within the context of Sub-Saharan Africa, who owns it, who uses it, and who benefits from it. We also think a lot about kind of regulation and innovation, so how those two things work. And in thinking through these themes, we think a lot about coloniality, which is kind of going to be the focus of my talk today. So I'll start sharing my screen now and hope it works. Can you see that? Okay, great.
Yeah, so we can see your notes as well. So if that's okay, so we can see the slide and then the next slide, and then the next slide.
Okay. Sorry. I was going to go back in and okay. So I'm going to start the talk by kind of illustrating for us what the major problem was. Thinking through this this problem on health data. I think in some ways, we had both the rhetoric. So this project began during COVID. There were lots of health apps all over the place. So there were health apps for contact tracing. There were health apps as part of clinical trials. And there were also kind of apps that were delivering adjunct health services. So lots and lots of health apps kind of delivering medical services of all sorts. And so there was, in some ways, the rhetoric of a very digital future. It's kind of waned a bit, but during COVID, there was a very real sense that the future was digital. But then there were questions of how that regulation might work, especially in the global south. But then there were also questions about what health data was. And I think that the example of Safe Border is a really good one. So those of you who've been to Sub-Saharan Africa and actually lots of Asia know that you have those motorbikes that deliver people, goods, services. And during COVID, lots of them were also delivering pharmaceutical products, sometimes vaccines. And so there was, in some way, a fungibility of kind of adjunct services that were linked to health. And so one of these companies in Uganda was then found to have shared data illegally. And there were real questions about what kind of that data was. So there was kind of personal data, which was being shared. But then people were arguing, well, it's delivering all sorts of services around healthcare, around vaccines. And so is that healthcare data too? So there were real questions about when does something become health data, which for us is always a very fungible question, especially with apps that we see as like platform apps, which are delivering financial services, for instance, is quite a big and central problem, I think, in our project. And so we were trying to think about questions of regulation and trying to think about how does regulation impact differently if we indeed think that this is health data, but also how does regulation look like for these services that are new and interesting and really were very exciting at that point. And so we had quite a lot of rhetoric post-COVID-19 within the African continent around kind of the possible futures that digitization would bring. So it was supposed to have this transformative power that was going to do everything. And it really made us think about the ways in which digitization was used during the pandemic. So for instance, we see huge uses of digitization in surveillance mechanism through health apps. So in all our case country studies, which are Kenya, Uganda, and South Africa, you had surveillance apps being used for COVID, and actually later in Uganda for Ebola as well. We saw a lot of digital health information apps, kind of dispelling myths being used. And some of these were specific apps that were introduced for that purpose, but also some of it were apps that were already in existence. So for instance, the Ministry of Health using WhatsApp in various regions. And then we had a lot of rhetoric around what the post-pandemic period brought, because there were apps that were being used for telemedicine, for instance, and there was an idea of what the future might look like post-pandemic in terms of this being increasingly seen as being vital for delivery of health services. But also post-pandemic, we had this idea that digitization was going to be really critical for delivering universal health coverage, which many people argued was quite critical to delivering health services in sub-Saharan Africa. And so digitization in health was being thought of as fundamental to pandemic preparedness, resilient health systems, but also making the very possibility of universal health coverage possible in sub-Saharan Africa. And the World Health Organization really took on board this idea of digitization of health. And in 2023, for instance, had asked India to lead, which was the head of the G20, to lead a global initiative to support the implementation of the global strategy of digital health, which runs from 2020 to 2025. There was also because it was used a lot in clinical trials, we also had better diagnostics. So there was a lot of excitement around this idea that there would be personalized medicine, but also in terms of pandemics, that we could really harness the potential of AI in the fields of diagnostics, in clinical trial, and essentially at the end of the process, maybe for personalized medicines. But what we were interested in thinking about was notions of extraction in terms of, again, questions of ownership and use, and also really thinking through whether some of the claims really matched up to potential benefits that might be gotten from this process of digitization. And so there on that slide, you have a couple of programs that are kind of really leveraging this idea of kind of potential in the future. And I think we then thought about kind of digital health coloniality and as kind of both a process of theorizing and understanding this process a bit, but also helping us to kind of really think through what possible futures might look like. So digital coloniality refers to the systemic and structural violence of human life through technological systems, which are designed to exploit everyday socialities, localities, and temporalities of individuals. And we really think about coloniality within the context of big corporations, which predominantly are based in the global north, which center their business model on datafication, which thinks about human life as a commodity. And there we're really interested in thinking about how health itself is enmeshed in this process of datafication. In the context of global health, we are interested in thinking about the ways in which coloniality enables the ability to collect, process, and store health data, and how this in itself becomes a form of power that reinforces existing hierarchies that exist within global health. Global health itself has always been enmeshed in a project of coloniality in some ways. So if you think about kind of really the colonial days and thinking about both people in colonial lands as a basis of experimentation, but also as a basis of kind of labor that then needs to be very productive. And so their health outcomes are really ensnared in the colonial project. And so what is really complex about the ways in which I think we think about coloniality now is the ways in which it's enmeshed in what looks like equitable partnerships. So we are thinking a lot about African leaders really seeking digital health and other kinds of digitization as a form of equitable partnership for development. And we're really interested in querying how equitable those partnerships are and what questions we might want to think about in terms of thinking about what coloniality might look like. And so we've looked at the literature on coloniality, and we kind of think that there's quite a lot actually in global health in terms of really thinking through those relationships, because they're kind of so old and really sustain the discipline. And we try to think through the ways in which digitization of health is really replicating those models of coloniality. The first way that we were thinking about was thinking about the supremacy of knowledge systems. And this was through institutions and knowledge from the global north always being taken to be supreme, and the ways in which, in some ways, digital health, with its idea of modernity, was being taken to be seen as something that will kind of, as an epistemic project that was going to kind of save in itself people from sub-Saharan Africa. And so we found this really interesting in terms of the way in which some of these ideas, or for instance, so the reason that I have Ruto in Silicon Valley there is that we kind of have the Silicon Valley in California and this idea that there will be like a Silicon Savannah in Kenya. So you're replicating these knowledge systems that are kind of replicating from the global north to the global south, but also taking some claims from those kind of knowledge systems as kind of being supreme. And so we're really interested in that. The other thing that we were interested in terms of that notion of thinking through coloniality was that idea of kind of modernity and rationality, so that digital health systems are positioned to offer this kind of preconceived idea of global health that is universalized, that is equitable, but also that is kind of modern. So it's very futuristic. And so we've been tracking a bit some of the rhetoric around digital health coloniality, and it really kind of echoes this idea of modernity and rationality. There's ideas, so for instance, when you hear Ruto Kagame speaking, there are ideas about this kind of being the fourth or fifth industrial revolution. We shouldn't be left behind. And so there's a very real sense that if we do not accept kind of an idea of digital health, this will kind of be problematic. This will be problematic for the global south. And so we think that these rhetorics of modernity kind of serve to reinforce coloniality in the ways in which kind of space and time are kind of really kind of narrowed. So you have space and time being narrowed. So you have these silicon places being almost like spatially looking very similar to each other, but also really not taking into account any of the local realities. It's almost just like, this is a replication of what exists in California, and therefore we should have it. And we think that that kind of serves to dehumanize, but also to treat this place that's the other as part of kind of this same mission. So this place that you start of thinking there, this data subjects that we need in order to study them becomes the same as you, and you don't need to take context in any way very seriously. And so these people who have their own very rich history, language, culture is almost flattened by this mission of really kind of thinking about this as kind of this modern or rational project. The other thing that really struck us was to think about the ways in which infrastructure was being used here as a mechanism of thinking through coloniality. And we thought about kind of lots of forms of infrastructure. So at the moment, there are lots of physical infrastructure. So you have these in hospitals everywhere that are kind of physical bits of infrastructure in order, for instance, to enable surveillance. But none of these infrastructures are produced in Africa, where thought about, like Africa wasn't thought about as a kind of a particular site. And so it was really interesting to think through what these kind of physical infrastructures do, both in terms of the apps that are being moved around for contact tracing, for instance, which are really thinking about kind of geographical spaces in a very different way from the ways in which geographical spaces are imagined in our case study countries. And so one of the things that we were keen to think about was kind of what do those infrastructures look like? So those infrastructures of collecting data, of processing it, but also increasingly the physical infrastructures you need for storage. Ensuring that kind of the data is useful. And one of the things that we were struck by in this process was how, because infrastructure was generally imposed one pandemic at a time, and we have really interesting case studies thinking through what's different between COVID and Ebola in Uganda, that the infrastructure was very specific to that pandemic. And therefore, the infrastructure was, one, not capable of speaking to other bits of infrastructure within that system. So we had real instances where it was not interoperable, and therefore bits of health apps, for instance, the health app that was introduced for COVID, not being able to speak to any parts of the health system within the Ugandan context. And so we were really thinking of that. If we thought of infrastructure as an imposition, what logics would it help to kind of to reproduce within that context? The second bits of infrastructure we were thinking about was kind of through software. So increasingly we had software, and really thinking through kind of ideas around language, what was lost in the ways in which language was kind of being reproduced in kind of these binary terms, but also kind of the software itself and intellectual property that might be necessary in order both to ensure that this infrastructure was, so that kind of bits of software, for instance, were being used by particular health systems. And the reason, so many of these were not open source. They had intellectual property, which meant that people could not kind of break into them in order to really think through what they were doing, but also could then not really think through about kind of data as an artifact from that infrastructure. And so that was really kind of another interesting thing that we were thinking about. And the final thing that we were interested in thinking about when we're thinking about infrastructure was storage, and really thinking about the cloud. So many of these systems either kind of by design or kind of by default, store their data outside countries, so store their data outside the countries involved. And in some instances, we are really kind of exploring what happens when countries need to access this data. And sometimes this is benign. So data is stored in the GOAN system in the WHO, but countries then have to ask the WHO for access for this data. And so really kind of thinking through ideas of data that is stored in ways that countries cannot access, being really interesting for us to think about. And the reason that we are really kind of keen on thinking about storage is that in Kenya before the pandemic, there was a case that went right to the Supreme Court that involved the Kenyan elections. And this case involved elections where they had their first digitized election that was disputed. They went to court. They then asked the company that had done the kind of data analysis for access to this data. And the company said, like, we can't release this because actually your data, like the ways in which you process your data are not robust enough. So this was kind of a European company that said the ways that you process your data are not robust enough. And therefore, this company refused to produce the data when kind of the highest court in the land had asked for this data. And so this kind of is an extreme case, but we're imagining, so you have an extreme case where a Supreme Court is asking for data and it's being denied this data of Kenyan citizens for an election. But like, can you imagine the powerlessness if it's just a provincial health authority who wants access to data and therefore cannot access it? And so we thought really through the idea of how infrastructure colonialism works in this way, through both denying people access, but also making the idea of storage something that kind of happens from outside, either by design or actually in terms of replicating that storage in some ways. So we were really interested in kind of thinking through how that works. The other thing that we saw when we were thinking about infrastructure were questions of financing. So a lot of the infrastructure was being financed by somebody else. And so questions around data were really, in large part, really linked to kind of who was financing them. And I will talk about kind of financing later on as kind of something that was really central to kind of thinking through the colonial, like the way in which we thought about coloniality in this space. One of the things, the other thing that I was also very clear to us was, I guess also because we began in COVID where borders were closed, you couldn't travel to East Africa. And actually, if you remember at that time, so South Africa, for instance, had the Omicron variant, where after it kind of both alerted the world to Omicron, borders, like there were lots of border closures to sub-Saharan Africa. And so it wasn't just South Africa being penalized. Actually, it was lots of sub-Saharan Africa being penalized. And so one of the things that we were really interested in was why we kind of had this idea of kind of a border politic that was for us very reflective of a colonial border politic, where during colonial times you had in some ways a sense of a rule of people who were outside your jurisdiction in their country, and this kind of being replicated in the ways in which health data can travel. So health data was traveling at all times during surveillance. Health data was traveling during kind of genomic sequencing data, which was traveling to the global north. But people were being kind of firmly told you can't cross these borders. And so one of the things that we identify is the border politics through which borders become close to humans, but health data can move kind of much more easily. And I think it's really kind of super important to think about in this moment when borders are becoming kind of much more of a thing. We are deciding that we need more controls, less people moving from the global south. Even during a climate crisis, we're deciding we don't need anybody. We're really full, but we're very open to the idea of health data moving. And actually, we are very dependent on the idea of kind of big data sets. And those big data sets must include data sets of people in the global south. And so it's kind of really one of the things that we kind of think through in the project, kind of what that kind of must feel like. Because I think when you think through a lot of the rhetoric around data, for instance, for AI, one of the important things here is that data must flow unrestricted. It must be huge, and it kind of must be abundant. So like it must be abundant and you must kind of have a lot of it. So you must have this kind of steady supply. And I think this really is in sharp contrast with kind of border closures and is linked to ideas of the global south being kind of vectors of disease and of being places of where kind of people are kind of useful kind of health data subjects. And so the next thing that we were trying to think about was ideas of philanthropy, aid, marketization, but these are kind of linked very firmly to ideas of financialization. So they are increasingly huge donor programs. So things like Measure, which is a USAID program, which works primarily in sub-Saharan Africa in order to use data to improve health systems. And we kind of see that these programs, for instance, if you zoom in and study them, you don't really kind of see any ideas of them thinking through ideas of stewardship of data, location, measures of storage, of data governance. Really, lots of these projects are really thinking about kind of a way of homogenizing, of treating lots and lots of different countries and giving them kind of one composite measurement of data for a health system. And so not enough work is being done in these projects to really think about the particularities of health systems, but also increasingly, a lot of this work is being done by donors like USAID in collaboration with universities in the Global North. So for instance, for Measure, it's North Carolina, and less emphasis is being put on the state. So the state becomes completely absent from the delivery of healthcare provision because it's being largely done through kind of philanthropy within kind of this context. The second thing that we think about in some ways is marketization. So we see lots of ideas around the idea that you have something that was a health system, but is now being delivered through kind of these health apps. Most of the health apps that we have seen are private health apps. So we've done kind of scoping studies across our jurisdictions. And largely they are private health apps that are now looking in order to kind of expand markets. So you find them kind of really thinking about this as a health market. And again, this relegates the state to being an observer within the process, but also kind of really puts a huge value on the idea of the market as something that is kind of critical in the delivery of healthcare provision in sub-Saharan Africa. The way of sustainability of all of these apps is through kind of marketization, of growing bigger, of platforming. So it's not only that you deliver health services, but you must deliver insurance, you must deliver financing. And so there you kind of see a real process of really kind of expanding health services through this idea of marketization. But also that has kind of particular problems because the way in which marketization for health works, and we see this in the UK, is that when you have the market dealing with health problems, you never deal with the most serious health problems because those are expensive. So there's a reason why private health insurance, for instance, in the UK doesn't have accident and emergency. So when you're seriously ill, you go to the NHS, which is kind of the provider of first resort. And what we see increasingly in some ways is this marketization is leading to kind of this idea of low-hanging fruit. So there's a lot of dermatology, there's a lot of wellness being provided. And so what is being provided for is not the extensive service that you need in terms of health services, but it's kind of particular health services that are really quite easy to marketize and that are quite profitable. And then there's kind of the bundling that we see. So you need to have kind of entire platforms that deliver things, which I think is also really important. And so I have like, I guess, two final slides before I finish. I think the thing that we also kind of were thinking about in terms of thinking about coloniality was, in some ways, sub-Saharan Africa's sites of experimentation. So the quote there that we have is around this idea of let's kind of experiment, but also let's do it really, really rapidly. So I think Mark Zuckerberg is quoted as saying, move fast and break things. Unless you're breaking things, you're not moving fast enough. And so while this might kind of seem like the hyperbole that you have, we actually are seeing this a lot in the ways in which big tech companies with kind of their unlimited budgets are moving really quite quickly within the health space. And some of this is quite experimental in terms of they are just kind of protecting their market dominance. They are acquiring lots of health services without a kind of a particular idea of how these health services fit within wider health systems. And so we are seeing these places kind of as sites of health experimentation, of datafication of health, and really thinking through how that might work, for instance, in terms of kind of behavior, in ways in which might be unacceptable in other places. And I kind of think this idea of experimentation actually both, although it comes as a form of kind of trying to widen the market, shrinks the market, because what happens is things get absorbed and then become part of like one health product, but also really enables kind of local talent to be poached by these big corporations. So, and that leaves kind of local tech companies understaffed because they can't really compete. So you kind of have this real push both to experiment, but through the experimentation, you then take off the best talent. And then therefore you reproduce this idea of this place without talent, when actually lots of that talent has just been absorbed in other spaces. And so we then, in kind of our work, are proposing kind of what a decolonial agenda might look like. So if we take seriously that this actually is a form of decoloniality, then actually our decolonial agenda is to really kind of move from this idea of generalizations, from kind of the rhetoric of this is all good, this is all amazing, digitization is going to be amazing, it's going to provide all of this, and really take the empirical case studies seriously in terms of national context and sometimes even regional context. So digitization of health aims to flatten, to provide uniform solutions across the globe. But we really kind of think that this is going to fail because you need to really center local communities in thinking through what those local communities need in terms of their health outcomes, but also to design health solutions that are really tailored to those local solutions. Conceptually, I think we also need to think through what digital health might look like, what resistance might look like. And resistance here might take kind of both kind of a conceptual form of reimagining ideas of who owns health data, what it's used for. And in the paper that I kind of attached to this presentation, we've thought through kind of some intersectional theories around Ubuntu, thinking through ideas of communal health data, what it's used for, but also kind of using the theories of kind of accountability, conviviality, respect in those, in order to think about how we could design regulation differently. And by regulation, I don't necessarily mean laws, although we might want to think about what laws might look like, but I also mean thinking through kind of what stewardship might look like in terms of kind of data that is owned by groups. And then lastly, we really kind of question whether we kind of need all of the stuff that we find. So there is lots of digital health technologies being produced very rapidly. And there are real questions about whether we need them all, because in our experience, these are sometimes through transplantation. Some of them are solving problems that don't exist. And this is really creating fragmentation in health systems. So thank you very much. I look forward to hearing your thoughts. and answering any questions.